out of your
It might seem crazy what I'm about to say. Sunshine, she's here, you can take a break. I'm a hot air balloon that could go to space. With the air, like I don't care, baby, by the way. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Here come bad news, talking this and that. Well, give me all you got and don't hold it back. Well, I should probably warn you, I'll be just fine. No offense to you, don't waste your time. Here's why. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Hey, go. Bring me down, can't none bring me down. Your love is too high. Bring me down, can't none bring me down. I said, bring me down, can't none bring me down. Your love is too high. Bring me down, can't none bring me down. I said, clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. Clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. Hey, go. Bring me down, can't none bring me down. Your love is too high. Bring me down, can't none bring me down. I said, clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Hey, hey, hey. Clap along if you feel like that's what you want to do. Clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Hey, hey. Clap along if you feel like that's what you want to do. Come on. It might seem crazy what I'm about to say. Sunshine, she's here, you can take a break. I'm a hot air balloon that could go to space.
welcome everybody. I'm having a little bit of technical difficulty here, but I'll just say that the reason we're playing the happy song is because the Surgeon General announced this week that we're doing a national hypertension challenge to finally take this issue as seriously as it should be. Many of you know that my mother died just a couple months after being diagnosed with hypertension. She died of a stroke. And so it's a really happy day for the Right Care Initiative that this topic that we have been pressing on since 2006, when I was asked as a regulator for the state of California to review thousands of pages of data and come up with a quality improvement program. There is CME today, so we'll have this in the chat box for you all to sign up for it. Next. Most of you know me. I've been at this for a very long time, working with Reverend Warren Barnes, the chief lawyer for healthcare for California for decades. He helped me found this project, and he created the principle by which we gather in this collaborative to drive down heart attacks, strokes, heart failure, and diabetes. Warren Barnes can't be with us today, so I'll just say that we compete against disease and not each other. And I'm sorry that he's not here to state that challenge for us. So we have some fantastic programming coming up, which includes having the head of the National Heart, Lung, and Blood Institute with us on November 9th, thanks to one of our speakers today, Dr. Bob Kaplan, who was his colleague at NIH before he returned to us to come back to Stanford. So we'll be sending out information about those meetings, but I wanted to say that our team has been very engaged in lobbying the Surgeon General, particularly Chairman Bill Bommer, Dr. Scott Flynn, who used to be with the Navy SEALs as their chief medical officer, and Dr. Joe Skye. We pulled together a private sector roundtable, which included the top brass from all the health systems in the Capital Region. And we were hosted by the Sierra Health Foundation for a 3-hour session with the Surgeon General summer 15 months ago, where we really pressed him hard to create this hypertension challenge. So of course we can't take all the credit for it, but we sure feel like it was a very moving day. And when the Surgeon General announced the challenge this week, I felt like the 14 years since I started the Right Care Initiative on my desk, reviewing the data about the terrible level of hypertension control, among other key data points, that we together as a collaborative have made a little bit of a dent in this issue. So let's look at that data slide if we could. This is if you look down to the third bar here, you'll see that in the Capital Region, where Chairman Bommer has done a fantastic job with our leadership team driving, we now have all of the major health systems in the Capital Region of Sacramento hitting at least 70% control for people with diabetes and their hypertension. So we're really, really proud of what the team has accomplished. All good things are accomplished by team. And I want to just say how much I really appreciate our team and realize that we have a long way to go on our metrics, but we are making substantial progress. And thank you for your leadership, Dr. Bommer. So With that, let's go to the next slide, please. I'd like to introduce our statewide chairman, Dr. William J. Bommer. He will be facilitating the meeting today. He has been a champion for this work for his entire career, whether it was with the California chapter of the American College of Cardiology and his leadership there, or training hundreds of cardiologists at UC Davis who are now all over the country. And with that, Bill, I'll hand over the podium to you. Thank you.
Thank you very much, Hattie, for that ultra kind introduction. I'm not sure who that is. At least my wife would not recognize who you introduced. But anyways, we have, and I'm delighted today to have a great program for everyone who's joining us today. I would like to thank the team, as Hattie said, including our co-chairs, Drs. Chen, Ivy, Sky, Stock, and Zaire, who've also are co-chairs for today's program. And like to welcome all of the members who are joining us today. Next slide. So the program today that we've outlined is going to start out with a disease that's been around for decades and decades, but we literally had not much to do as far as diagnosing it other than autopsy. And at that point, it was too late to help the patient. But there's been major changes in the diagnosis of it and in the treatment of this disease that now makes it something that is no longer a life sentence for individuals with it. And we are realizing it's much more prevalent than we thought before. And now that we have both diagnostic and treatment modalities, there's been really breakthroughs in that Dr. Grogan from Mayo Clinic, we're delighted today to have present that. We'll talk a little bit about the affordability of those therapies. And then later, Dr. Kaplan from Stanford will summarize what we know in an evolving program of treatment and diagnosis of COVID-19 as we go forward. And we'll have a little time for questions at the end. Next slide. So I'm delighted today to introduce our speaker for amyloid, and Dr. Grogan is with the Mayo Clinic. She's been there for years, including her training there over the years, and has done a great job in establishing a amyloid clinic there at Mayo Clinic. She is very well published in all of these areas, is an expert in the field, and I would say we're delighted to welcome today the world's expert on amyloidosis making the presentation today. And without further introduction, because I want to go right to her presentation, we'll go into her talks for that.
Great, thank you so much, Dr. Bommer. This is really my pleasure to be part of this initiative. It's so important. I also think what an uplifting, to have the happy song right before a talk, is really a great motivator. And we are truly so happy about all the progress in cardiac amyloidosis. So it's really taken this from an untreatable academic disease to a condition where in certain patients, we may actually be able to prevent heart failure. And that is, of course, so exciting. So I'm going to just start my slideshow. Again, I don't know why it was, there we go, back, there we go. So does everybody have the first slide there now? Are we all okay
Yep.
on the screen? So we'll talk about cardiac amyloidosis, both AL and TTR amyloid. You really need to know about both types. Sometimes people say, I just want to learn about that more common TTR, but there's a lot of overlap. So our providers need to know about both. I have research funding from Alnylam, Eidos, Pfizer, and Prothena. That is not personal compensation, that is to the Mayo Clinic. And I hope to get a few new followers on Twitter where we talk about all kinds of things related to amyloidosis, including the cost of the medications. So I know we'll have somewhat of a mixed audience, but I want, whether someone's a cardiologist or even or a general internist or a hematologist, think about if you get a new referral and the patient has a diagnosis of transthyretin type amyloid made on the basis of a positive PYP scan, then think to yourself, what are the three clinical questions that you are going to ask yourself? What is the ventricular septal thickness? What's the heart to contralateral ratio? What's the echo strain value? And what is the pattern? Those might be some of the questions you might ask, and we'll come back to what you probably should ask a little bit later. And I thought we'll keep this as interactive as we can, recognizing our Zoom format, but I want to just kind of walk through some cases with you. So this first one is a 66-year-old gentleman who presented with exertional dyspnea. He had a history of coronary disease and had had several stents placed, and he did present with exertional dyspnea prior to each of those interventions and then got better. No history of hypertension, but about a year before we saw him, he noticed again dyspnea while he was hiking, initially at a pretty significant incline. He had a repeat cath by his local provider that showed only mild coronary disease, no significant restenosis of the areas of the stents. But then the dyspnea got worse. His NT-proBNP was over 2,000, although it did drop down to about 500 with low-dose Lasix. Then closer to the time where we saw him, he presented with a renal infarct. He had a 30-day monitor and no atrial fibrillation was found. However, at this point, he did have cardiac imaging. His echo showed very severe increase in wall thicknesses. The left ventricular walls were 18 millimeters. His EF was preserved, but his strain was quite abnormal with a pattern consistent with amyloid, and he had elevated right ventricular systolic pressure. His MRI also suggested amyloid, and actually on the MRI, they saw left atrial appendage thrombus. He had a serum protein electrophoresis, no monoclonal protein, and then he had a technetium pyrophosphate scan. We're going to talk about this a fair amount for anybody who isn't familiar. And this was markedly positive and consistent with TTR amyloid, with the heart to contralateral ratio of 2.4 at 1 hour, where positive would be greater than 1.3. And the SPECT imaging showed uptake in the myocardium. He did have a little bit of elevated creatinine, and by this time now he has markedly elevated biomarkers. His NT-proBNP over 7,200, and his high sensitivity troponin was quite elevated. He did not do very well on his stress test, only went about 42% of predicted. So you'll have to just write down the answer, to be honest with yourself, of what would you do with this gentleman now? Would you give him tafamidis, diflunisal, patisiran, maybe he should get a heart transplant, or maybe something else? So to go on here, the correct answer actually for him is something else. There's something missing in this presentation that I just gave you. And what was missing were the serum free light chains. And in his case, his lambda free light chains were markedly elevated, 41.8, upper normal is 2.6, and he has a markedly reduced kappa lambda ratio. Turns out when you do the serum protein electrophoresis with immunofixation, then you find a lambda monoclonal protein, and we'll talk a little bit more about that going forward. But many times I have found out that even if clinicians appropriately order serum protein electrophoresis with immunofixation, many labs just do a serum protein electrophoresis, and only if it's abnormal do they do the immunofixation. And that is wrong, and you will miss AL amyloidosis if that's the way your lab works, but it's kind of tricky to find that out sometimes. In his case, the fat aspirate was negative for amyloid, bone marrow showed 8% plasma cells, but was still negative for amyloid. So we had to go to an endomyocardial biopsy to prove that he had AL amyloidosis in his heart. And the reason that this is so important is that although he had characteristic echo and MRI, and he had this positive PYP scan, which many people recognize is now a way that we can make the diagnosis without tissue. You can't do that if you have not completely excluded AL amyloid. And again, he had the wrong test performed. But before he got to us, he was actually diagnosed with wild-type TTR amyloid and prescribed tafamidis. But instead of tafamidis, what he needs is chemotherapy. So now we had, almost a year of symptoms and 6 months of significant symptoms. And we had about 3 or 4 month delay with this idea that he had wild type TTR that he didn't have. So I'll review that there are over 30 different proteins that can cause amyloid. And fortunately for us as cardiologists, there's only 2 really common types that affect the heart. So light chain amyloidosis, where the protein factory is the plasma cells in the bone marrow. So a clonal plasma cell disorder leads to an excess production of immunoglobulins. And here you see the heavy chain and the light chain. And now we can measure these easily in the blood, readily available test. And then those subunits kind of glom together. They form amyloid that gets into the heart and other tissues. And here you see transthyretin amyloid has a completely different protein factory. In this case, the protein is produced in the liver, although there's no hepatic abnormality. But after transthyretin is produced, it becomes unstable. So transthyretin transports thyroxine and retinol binding protein, which thyroid should bind right there. But it's breaking apart in these people with amyloid. In hereditary patients because they have a mutation and less stable protein. But then you see the subunits kind of glom together and they form the long stringy-like stuff that we call amyloid. So although there are a lot of similar features, these 2 proteins come from totally different places. And wild-type TTR, wild-type is just a genetics term, meaning that there is no apparent mutation, and this type does not run in families. This is what we used to call senile systemic amyloidosis. And then hereditary patients do have a known mutation. So when you look at these 2 main types, once they get to the heart under the microscope, they will look pretty much the same to the pathologist. So if you have tissue, for example, you have to do special tissue typing, best done with mass spectrometry. So you know exactly what type of protein makes up these amyloid fibrils. And kind of a key thing that's very important that a lot of cardiologists don't recognize is that over the years, we've thought about amyloid as an infiltrative cardiomyopathy, which it is infiltrative. Here are the amyloid fibrils, in an extracellular position. But there's also a toxic component to it. And here you see the myocytes being directly affected by the cytotoxic effects of circulating light chains. And this probably also happens with the subunits of TTR amyloid, but it's a very important concept. It's the reason that some people with AL amyloidosis don't have that much infiltration, but they can still have very severe heart failure due to ventricular dysfunction from the circulating free light chains. So one needs to be very cautious in the imaging. I'm always a little worried if an echocardiographer says advanced cardiac amyloid based on the imaging findings, because sometimes patients who don't have a very thick heart have very severe heart failure. That's usually an AL patient. And in contrast, these TTR patients can have some of the thickest hearts you've ever seen, but they may have a much better state of hemodynamic compensation. So it's really more complicated than that. And even though classic amyloid is pretty easy to diagnose by echo and MRI, recognize that historically we've been seeing relatively advanced cases. And now that we have treatment for all types of amyloid, the real key for cardiologists is to pick these up earlier, whether it's AL, because these patients need chemotherapy or stem cell, or TTR, because now we have drugs that might significantly prevent the progression. So it really is not a single disorder. There's all types of variations, and especially for imagers to recognize that they don't all look the same. And that's really a challenge for us to think about. Well, when we look at the features of these different types of amyloid, AL, as we mentioned, comes from the bone marrow, plasma cell disorder. And often this is a multi-organ condition, but sometimes the heart is the predominant organ involved without much extra cardiac involvement. If you have a patient with hepatomegaly, peripheral and autonomic neuropathy, nephrotic syndrome, these things, then that's quite a clue. Macroglossia and periorbital purpura, which will make it into a lot of textbooks, are almost pathognomonic, but they're not very common. And carpal tunnel can occur with any type of systemic amyloid. The hereditary type of amyloid can present either as heart failure or peripheral or autonomic neuropathy, or an overlap between the two of those. But it's important to recognize that only about half of patients with hereditary amyloid have a known positive family history. So you can't use a family history alone. And of course, there's variable penetrance. So not everyone who has these mutations will actually develop amyloidosis. But very important to recognize, in the United States, about 4% of Blacks carry the V122I mutation. So that's a huge percentage of individuals who are at higher risk of developing heart failure due to amyloid. And the other common mutations in the US are shown there. I'll caution people that they changed the number of amino acids. So technically you'll see V122I as V142I, but most of us that see a lot of patients still use the older legacy nomenclature because it's in the literature a lot. So that can be a little bit confusing. And then wild type TTR amyloid really is probably the most common type that affects the heart. And once you start looking for that, you will find it everywhere, but you'll start finding these other types and even some other, even more rare types that we're not going to talk about today. So these patients often present with carpal tunnel syndrome. They might have biceps tendon rupture, spinal stenosis. Atrial arrhythmias and conduction system disease are very, very common in wild type patients. And all of these things can be years before. Spinal stenosis and carpal tunnel can be 8 or 10 years before any cardiac manifestations. Now, we don't know, do all patients who have some wild type TTR in their carpal ligaments, are they all going to get heart failure? That's a huge area that we don't know the answer to, but figuring that out is going to be very important. So these are patients we're seeing more and more, and we're starting to see patients earlier in the course of their disease. AL amyloidosis is really a race against time, and anyone who's seen these patients know how rapidly they can deteriorate. About 20% still die in the first 6 months. So once you are worried that a patient has amyloid, I think it's best to consider it AL until proven otherwise. Now that we have treatment for all types of amyloidosis, we really need to be fast. We can be super fast as cardiologists when we think someone has a STEMI, and we need to be, similarly quick, maybe not quite that fast with AL. So I just made up this rule, but give yourself about 1 week to get all the tests that you need. This is not something like the patient I showed you that you can drag out over 6 months, because then a subset of your patients are not going to make it. Once you figure out if there's amyloid or not, if you need tissue typing, as you always need with AL, it'll take you a little longer to get that, but by that time you should be on the road to having an expert involved. And why is this so important? AL amyloidosis, this is showing you survival over time, and this is even before the onset of the use of daratumumab, which is a very effective new chemotherapeutic agent. But you see that it's gradually improving over the time periods. This was the most recent in this particular study. Still a very bad disease. But if these patients can get to stem cell, so this is autologous stem cell transplant, they have a much better survival, and they're highly selected. Those are patients with either very mild or no cardiac involvement. But if we can get them earlier, notice that they have a 94% 2-year survival. And now chemotherapy is improving too. So all of these outcomes are much better with AL patients than what we have seen in the past. But many, many patients present first to a cardiologist. They often have to see 4 or more subspecialists to get a diagnosis. They sometimes get multiple casts, multiple echoes. And again, many of them are presenting with cardiac symptoms, especially those who end up with the most serious disease. So the key thing here is that the early survival is still not good, and we need to be quicker about figuring out what these patients have. Now let's talk a little bit more about these wild type patients. Again, what used to be called senile systemic amyloidosis. This really isn't rare. So we now recognize that it's more common in men than women, and it increases with age, but it used to be said that it would only occur in men over the age of 80. Well, now the youngest patient we've had was diagnosed at age 48 and actually had heart failure for a couple of years before. Women, we are finding women with this, and I don't know if they have a different phenotype, if their echoes look different, why it's harder to find women, but women do get wild type TTR amyloid. And we are learning a lot, so we need to have a real open mind with this disease because it's changing rapidly. But what we recognize right now today in 2020 is, as I mentioned, spinal stenosis, biceps tendon rupture, bilateral carpal tunnel syndrome, atrial arrhythmias, and conduction system disease requiring a pacemaker. Often all these things come first, and then finally we get the patient down here when they have heart failure. So we've been getting them late in the course of their disease. And even if you look back at autopsy series, we know that a lot of elderly people have amyloid in their heart, and recent studies have shown that a lot of that is TTR amyloid. Maz Hanna did a great study from Cleveland Clinic for bilateral carpal tunnel. Prospectively, they looked at tissue being removed. Most of the time, the hand surgeon isn't sending this to look for amyloid, although a lot of them are starting to recognize the importance now. So men over 50 and women over 60 who had bilateral carpal tunnel syndrome, in 100 patients, or almost 100, he found 10% of them had amyloid. And notice that half were wild type, but he found some hereditary patients, 2 AL patients. There was 1 AL patient with florid heart failure that hadn't been recognized. HFpEF patients in this important series from Spain, about 13% of patients had wild type TTR. Lots of studies going on around the world to try to see, replicate that and see how common it is in other populations. We know that when patients are undergoing TAVR, about 15% of them have wild type TTR. And spinal stenosis, that's a big grab bag. One study said 100%. Well, it couldn't be 100%, but it's a lot of patients. So certainly cardiologists really need to know about wild type TTR amyloid. And we're going to need a network of local, regional, and national experts, which is going to fit perfectly with your initiative to try to make sure that we are making the right diagnosis and getting patients on the proper therapy. Here's just an example of how many of these patients look and why, if you've historically seen AL amyloidosis patients are very sick, you're not going to think that this person has wild type TTR, but many of them are avid exercisers. They often have very few cardiovascular risk factors, and they're shocked to get any type of cardiac symptom, but he was an avid cyclist who had wild type TTR amyloid. One of the really revolutionary things that's happened in the field of amyloid has been the acceptance of nuclear cardiac scintigraphy to make the diagnosis of TTR cardiac amyloid. And this is the result of the International Consensus Panel convened in 2016. And I will say that when my colleague, Dr. Dispenseri, who's a world expert in AL amyloidosis, and I went to this meeting, we were pretty much against this idea because up until then, amyloidosis always required a tissue diagnosis. There was no other way to make the diagnosis. But when we looked at all the data in conjunction with all these other people in the group, we did conclude that bone scintigraphy in the US, we use PYP, that we could use that to diagnose TTR amyloidosis without histology in patients who do not have a monoclonal gammopathy. And also, importantly, in this paper, it required that patients have typical echo or MRI findings and that they have a history of heart failure. So it's not just any person coming off the street having these tests. In Europe, they use different agents, so you'll see DPD and HDMP. But remember that in the US, PYP is the scan. You can't use some of the other bone scanning agents. So the key thing is, because whenever we have a new test, cardiologists get very interested in it. We love imaging, but we have to make sure that we're doing it right. And you have to really, right now, I think you still should require heart failure or some type of cardiac symptoms with some typical findings. I'm very nervous if a person has kind of a normal looking echo and a positive PYP and calling that amyloid. But more importantly really is the importance of thoroughly excluding monoclonal protein. And what does this mean? This really means that you need to have a normal serum free light chain ratio and no monoclonal protein in the serum or urine by immunofixation. And I'm going to say this about 4 different ways, but here's an AL patient with uptake, and I already showed you our patient in the first case. And a very important thing is that in the age group of individuals who get wild type TTR amyloid, 30 to 40% of them will have a monoclonal gammopathy because it's common as you get older. But the monoclonal gammopathy can be completely unrelated to what's going on in their heart. But based on the consensus guidelines, if you truly have a MUGUS, you cannot use the PYP scan alone. And if you have an expert hematologist working with you, you can go through the algorithm that I'll show you. But as a cardiologist, if there's MUGUS, you need help in making this diagnosis. And one way of remembering this, Dr. Dan Judge came out with this nice little mnemonic for us, is that if you have MUGUS and you're trying to diagnose amyloid, then you must go under the skin. That means you need to get a tissue biopsy from some part of the biopsy of the body to make that diagnosis. So that's an easy way to remember it. And the key thing, and this was maybe not so emphasized in some of the earlier papers, is that even grade 2 or 3 significant uptake of pretty strong uptake of PYP may occur in the myocardium and AL amyloidosis. And this is the patient that I showed you that got misdiagnosed. So you need to really make sure that you understand that concept. And I don't think you'll forget it now. So here's another interesting patient. And when we saw him, he was 67. He had progressive exertional dyspnea, which seems to be what all my patients have. He had a known ascending aortic aneurysm, and kind of after a while, it was figured out that, oh, he actually had a bicuspid aortic valve. This was all elsewhere. He had moderate aortic regurgitation reported. His EF was a little bit reduced, and his wall thicknesses were somewhat increased. He had a PYP scan done elsewhere, which was interpreted as positive with a heart to contralateral chest ratio of 1.8. He was started on tafamidis, and he came to see us for a second opinion. Now here's a still frame of his echo, and you'll see he's got a dilated left ventricle, and his walls really aren't very thick. I mean, the most we could measure was 8-10 millimeters. His LV mass could be a little bit high because he's got LV dilatation, but look, his LV was 64 millimeters. And our Mayo echo was interpreted as moderate aortic regurgitation. So this was kind of a puzzle. And I'm not going to show you all the images. We're not doing an echo conference, but he had a very eccentric jet of aortic regurgitation. And if we happen to have any fellows watching, this was also a case where the old-fashioned stethoscope helped out, because he just had an unusual aortic regurgitation murmur. And kind of made me think of patients I've seen with endocarditis before. I just was worried that there was a structural problem with this valve. When we looked at the descending thoracic aorta, there was a lot of diastolic reversal. So anyway, we went on to a TEE that showed he had a flail aortic leaflet, and he actually had severe aortic regurgitation. So this patient doesn't have cardiac amyloid at all. We took tissue just to make sure at the time of his surgery. So he doesn't need tafamidis. he needs an aortic valve replacement. But you notice one of the problems was he did not have a typical echo. In his case, AL amyloidosis had been excluded. So how could this PYP scan be wrong? Well, here when we repeated the PYP, the uptake of technetium pyrophosphate is all in the left ventricular cavity. It's a dilated left ventricle with aortic regurgitation. So that's why PYP is hanging around in there. And it's the blood pool, LV, not uptake in the myocardium. So that's a key thing for you. Again, for the right care initiative, you've got to get the right diagnosis. And those of us who see a lot of amyloid have just been, we knew that the world would change as more people started doing PYP scan, but I guess we didn't maybe know how fast it was going to get as scary as it was. So here's a paper that Maz Hanna and I wrote with others to illustrate that you always have to screen for AL. You always should do SPECT. And if you're still suspicious, you should do a biopsy because sometimes these tests are negative. So to avoid the perils of PYP, you should recognize that it probably can detect early disease. Actually, I'm sure that it can. But unless you have a person that's a carrier, that's the one situation. Right now in 2020, we really should have typical echo or CMR findings because those are the cohort of patients that was studied that led to the consensus guidelines. And then you always need to screen for monoclonal protein, and you need to make sure you confirm the uptake with SPECT. And as with any other test, once we start applying this to a lower pretest probability population, we're going to find other causes of positive PYP, which include, we've seen Plaquenil and other things. So we're going to learn a lot in the next couple of years. So back to questions you need to ask. What you need to ask is, was the echo consistent with amyloid? Has AL been excluded? And does the SPECT show myocardial uptake? And this algorithm shows you that if you start, most cardiologists are going to start with a typical clinical scenario and echo or MRI findings. We will need to figure out, how do we deal with those really early patients? But for right now, you start with that. Most of us believe you should screen for AL up front because you can't really use the PYP scan unless you know the results of those. And then if it's abnormal, you have to go down this route to get a FAT if you have that available, bone marrow, heart biopsy, or extracardiac biopsy, and do typing. And if you don't find amyloid in AL, remember you always have to have tissue. So if you don't find it from outside the heart, then you do a cardiac biopsy. If you do a cardiac biopsy with adequate sampling and there's no amyloid, then you most likely have excluded it. But if these tests are all normal and the clinical scenario, the echo fits, then that's when you can do a PYP scan. And then if it's positive, you have TTR amyloid. You always need to do DNA sequencing to figure out if it's hereditary or not. So that's the diagnostic pathway. And just remember, there's always exceptions, You still have to have a clinician with a brain to put this all together. And that's why there's all kinds of footnotes there. So moving on, just the last part here is to really talk about the exciting treatment that we do have for amyloid. It's totally directed at the underlying protein disorder. And as I mentioned, is very, very different, of course, from AL compared with TTR. So it's a tragedy to give an AL patient tafamidis, and we've seen the opposite, a TTR patient who's getting chemotherapy. Those are big mistakes that we don't want to have happen. So with AL, of course, we control the plasma cell disorder with chemotherapy or autologous stem cell transplant. And with TTR, we try to reduce or stabilize the transthyretin that's abnormal. And all patients, we have supportive treatment. We don't use standard guideline-directed medical therapy in most patients, even when they have low ejection fraction, because the mechanism of their ventricular dysfunction is not such that they're going to get reverse remodeling. Usually stopping these medicines make patients better. As we enter into more chronic era, never say never, there might be times when we use these drugs, but for most patients and most providers should not be using these. And so you're going to have that checkbox that's going to pop up. How come you're not using it? But these patients are prone to hypotension, autonomic neuropathy, and they have a low and fixed stroke volume, whether they're AL or TTR, and beta blockers especially just usually make them worse. Another important thing for cardiologists to recognize is that a lot of these patients will have intracardiac thrombus. We know this from autopsy studies and others, even in sinus rhythm. And here's a cardioversion study where we found that 28% of them we had to cancel, even though over 40% were on anticoagulation. And they get more complications than patients who don't have amyloidosis. So we do cardiovert these patients, but we always use TEE, and we're always pretty cautious to recognize that there could be complications. Many times these the thrombi will persist, so it's not necessarily a failure of anticoagulation. So what's the clinical course, especially of wild type TTR? It probably has a very, very long lead time. And when you start seeing a lot of these patients and seeing how abnormal the echo and the MRI, and if you cath them, the hemodynamics are, they often have hemodynamics that are almost incompatible with life. But they leave the cath lab and they pick up their cell phone. Well, you know, back in the day before COVID, they would say, oh, I got to go do a business deal here. Or then they go exercise or doing all these things that seem hard to believe, but probably because the body, the heart, the lungs, everything adapts over a long, long period of time. However, what I learned from one of my colleagues years ago is they do well for a long time until suddenly they don't. This is, of course, without any therapy. And then literally, it's like they fall off a cliff and nothing that you do will help with their heart failure. So that's why it's so exciting that we now have treatment for TTR patients, where in the past we had organ transplant, liver transplant for hereditary patients, but we didn't really have any other treatment. So I know Dr. Bommer is going to review this a little bit too, but 3 main ways that we can treat TTR amyloid. One is at the level of the liver to stop production. So very interesting that these RNA silencers, is the way most of us think of it, they silence the liver so that it makes very little transthyretin. It makes only maybe about 10% of what would usually be produced. And there is some TTR produced in other parts of the body, aqueous humor and CSF. But most of the TTR is kind of shut down by these drugs, inotericin and patisiran, which right now, those are only approved for hereditary TTR amyloidosis with neuropathy. A second way is to try to stabilize the protein. So the protein is still made, but it doesn't break apart. And that includes tafamidis, diflunisal, and AG10, which is in clinical trials. Patients will always ask you, what about breaking up amyloid? And it's important to recognize that in other types of systemic amyloidosis, most commonly AL, we know that if the AL is controlled, over time, organs, including the heart, can get better. Not only does a patient symptomatically get better, but we can sometimes see very dramatic imaging improvement. It's not real common to see the dramatic improvement, but patients get better. Their diastolic function gets better. So over time, the body can break down amyloid. And that probably will happen in TTR, but over what time period, we don't know. There's been a lot of interest in trying to disrupt these fibrils, including some drugs that in theory would work on any type of amyloid, but the clinical trials have been a little bit disappointing until now, or including now. There's one medication, PRX-004, that just finished a phase 1 study. That's for TTR amyloid. Doxycycline and TUDCA, which TUDCA is tauroursodeoxycholic acid, similar to urso that dissolves gallstones. But if you read on the internet, this old TUDCA will cure anything that ails you. That combination in a mouse model looked encouraging for disrupting amyloid fibrils, but we haven't had a lot of clinical data. So these drugs may be coming, but they're not ready for prime time yet. And so this just shows you what's FDA approved and what's not. But we have a huge amount going on. Liver transplant is only for hereditary amyloid. And that may or may not become obsolete. I guess you have to take the cost into consideration. But patients after liver transplant for a variety of complicated reasons can still progress. And heart transplant for any type of amyloid, both AL and TTR, it is a possibility for highly selected patients. But of course, with TTR, with any of them, we'd like to identify them earlier and not have to do an organ transplant. So the summer of 2018 was the very exciting year for these new therapies for TTR amyloid. In one edition of the New England Journal, we had both patisiran and inotersen reported. And again, those were studied only in patients who were hereditary and who had neuropathy. They could have cardiac involvement, but only NYHA class 1 and 2. And they both slowed the progression of neuropathy and improved quality of life, even a signal towards maybe they actually improved neuropathy. But they really were not designed to assess mortality or cardiac efficacy. And that's why the clinical trials are now ongoing. We did kind of beg these companies to study them in cardiac patients, but they decided to just primarily focus on nerves. So now we're doing the trials. Both of these have what I call next generation drugs, easier, that are more easily administered. The next generation of inotersen is sub-Q once a month, and of patisiran is, instead of being IV every 3 weeks, the next generation is subcutaneous 4 times a year. So if you think of the implications of that, that's amazing. And as Dr. Bommer is going to say, they cost a fortune. I'm going to let him talk about that part. Tafamidis then was studied specifically in both wild type and hereditary patients with cardiac involvement. So this was a cardiac trial, and it was pretty strongly positive, a 30% reduction in the risk of all-cause mortality in these patients, and the number to treat was 7.5. So this slows progression, reduced the mortality and the risk of CV hospitalization. And clinically, I will say, we see some patients where they're pretty stable. They don't progress too much at all. So particularly the earlier they are treated, the better they do. And that was shown in the study, another drug that cost a fortune. So my take-home points for you is that cardiac amyloid, if you start looking for it, you are going to find it. To do a PYP scan, make sure there's no monoclonal protein and make sure you do SPECT. And really, this has been transformed. It's still a very, very serious disease, but instead of being almost universally fatal, we now have a whole new group of patients with chronic amyloid cardiomyopathy, recognizing that cardiomyopathy is a little bit tricky term, but I think it's easiest. Chronic amyloid cardiomyopathy is now a new thing. So I thank you for your attention. I'll just show you a few resources that we use. We have our own amyloid YouTube channel that can be helpful for other providers and patients and their families. There are some excellent support groups and foundations for patients, so important in many, many ways. And then here's all the things that we have, genetic counselors and all kinds of things on that YouTube channel. So that's a source of information, and I'll stop there.
Well, thank you very much. We really appreciate that as the diagnosis and treatment of this disease evolves. We'll wait for a few questions to come up. We have a few minutes for that. And I think one of the questions that is in already was, how often do you see classical AL with cardiac TTR? In other words, let's say 10, 15% of individuals with aortic valve replacement or other groups might have wild type ATTR. AL is a much less frequent disease. Have you ever encountered it where they actually have both diagnoses?
That is a very astute question. So we have seen that. Our mass spectrometry laboratory, does a huge number of cases from around the world. So they have a giant database. It's been very, very rare. Less than 0.5%. I forget the exact number, but extremely rare to have two types of amyloid in one specimen. sometimes a patient might have AL amyloidosis outside of the heart, and then as they get older, they have TTR amyloid, but it's two different types of amyloid in the same patient. But both types of amyloid in the same specimen does occur. I have a few patients like that, but it's very, very rare. But I would say that it's probably, most of the time you can still feel pretty comfortable if the patient has obvious AL amyloidosis, especially if it's a woman, not very old. We're not too worried about it. It's more in men, once they're getting to be 55, 60, 70, that we get more nervous about relying only on the extracardiac specimen. So there's still a role for biopsy in that situation. And actually, that's sometimes where a PYP scan can help in reverse. You know the patient has AL amyloidosis. If the PYP is completely negative, then the chance of you having TTR or the patient having TTR is quite low. But that rare situation does occasionally occur.
Great. Another question is if 15% or 1/6 of TAVR patients have amyloid, for those individuals, should they be biopsied if we're in there with a TAVR, big, huge diameter catheters, that are there? Should we try to get a biopsy in individuals like that? Or would we just rely on the pyrophosphate scans for the regular workup?
That's a great question. I'm not sure if we know the answer. Now, in some centers are increasingly doing PYP. We haven't gotten to the point where we're doing PYP in all patients. I think there's enough ongoing studies that probably will answer it. Doing a biopsy is not a crazy idea, though, because then you have the gold standard diagnosis. And the other thing about TAVR, many of us initially kind of thought, gosh, these patients are just not going to do well with TAVR. Now, if they have very, very advanced amyloid, I certainly would be, and decompensated heart failure, I'd be hesitant to do a TAVR. But the patients that are more early or middle in their clinical course, when you reduce the afterload by getting rid of the aortic stenosis, the studies show that they actually do reasonably well. So Matt Maurer and others, we admit that we've been a little surprised by that. So I think it doesn't mean that you won't do the TAVR, but you're definitely going to consider, most of them are going to end up with tafamidis too. So I think biopsying them is not an inappropriate thing.
Great. Let's see, do we have any other questions? I don't see them listed here. Let's see. Okay, so we have a few more here. One is, how important is the toxicity from light chains versus the amyloid itself? In other words, you well described that there may be a direct toxicity from the light chains, but there is also the, quote, infiltration or accumulation of proteins. Do we have an idea of, is it 50-50? Is it
Yeah.
toxicity and less infiltration, or reverse?
I'm not sure we know how common it is, because unfortunately there may be a fair number of patients who had predominant light chain toxicity who never got diagnosed because they have an atypical echo. But clinically, I will say, so the exact percentages, I'm not sure of, but it's mostly important for clinicians to recognize the imaging variation. I have a fantastic example that they didn't end up showing you, of a patient who, she just has normal wall thickness, normal LV cavity size, but reduced ejection fraction. But then if you looked at her clinically, she had all these other clues: bilateral carpal tunnel syndrome, new low voltage on the EKG, all these other features that were consistent with AL. So the higher the light chains, obviously, the more likely that is to happen. But clinically, we know it's the reason why some of these patients respond to chemotherapy much more rapidly than you would expect. And that's because you've knocked down the circulating light chain. So a very important clinical reason that patients may, especially with better chemo, do better than you might think. The other thing is, some patients have primarily vascular amyloid, so they won't have very thick hearts.
That's great. Another question is, we do know that many of these patients have pre-existing involvement of biceps tendons, or as we said, for carpal tunnel. Should we convey to our other specialists who are more likely to encounter the biceps tendon, that's not going to go to a cardiologist, it's going to go to a orthopedic individual, or to carpal tunnel, convey to them that those patients coming in at a certain age should get or be left to go through the algorithm to rule out cardiac disease when they present in their 50s with bilateral carpal tunnel or with biceps tendon rupture, etc.
I think it's really important to raise awareness with the hand surgeons, the spine surgeons, and primary care providers about this risk. That's the kind of thing where now there's a lot of studies going on, so hopefully we'll know more. In our case, we've gone and presented to them and suggested that using the Cleveland Clinic data, if it's men over 50 and women over 60 that are bilateral, it's quite reasonable to take the tissue. Some people are doing it as part of a research, some people are doing it more as a quality initiative. What we don't know for sure is what to do when they come back positive. Most of them, we screen them with an echo, biomarkers, a PYP scan. If they're completely negative, then we generally follow those patients, and we don't know when the threshold would be to treat, but we find some of them where they are positive. So a lot of ongoing research, but I think it's definitely important to start reaching out to our colleagues in other disciplines and making sure they're aware of this, and we will have more information down the road. One thing, some patients, of course, are taking non-steroidals on a regular basis. Some of these younger patients that come in maybe for carpal tunnel. So if I see a patient, or even when I have a carrier patient, we don't have proof of what we should do as far as stabilizers, but if they're already tolerating an NSAID, they don't have a lot of risk. If they want to take diflunisal, it's not a crazy thing and it's very inexpensive. So if you prevent a person from getting heart failure and all, atrial arrhythmias and all these other things, it's a reasonable thing to at least discuss with the patient, but that's where we need more data. But I do that in my practice, and I also have even patients with established cardiac amyloid. If they are able to tolerate an NSAID, we have a group of patients that are on diflunisal, not tafamidis, due to the cost issues as well.
Now, is it ever too early to start treating these individuals? In other words, we look at pre-diabetes, we try to move treatment into that group of individuals earlier. Should we be thinking of very early treatment in these individuals, even if they are not symptomatic at the time?
Yeah, I think that's what we don't know. So early treatment, I mean, if we have evidence of cardiac involvement, if you have an abnormal echo and or a positive PYP, I think you can feel pretty comfortable treating them, recognizing that the tafamidis trial required heart failure symptoms and an NT-proBNP of 600. But if we have an NT-proBNP of 300 and a typical echo and PYP, we feel justified in recommending treatment, which usually would be tafamidis. But as I said, some very early patients, it will be diflunisal. If we don't have any definite cardiac involvement, that's the big question mark. Because maybe some of those patients remain isolated to the spinal and carpal ligaments. We don't know the answer to that.
Yeah, certainly our interest and our understanding of this disease continues to evolve. For personal history, when I was in medical student, my chief of medicine came to us and said, we've identified this amyloid protein in certain areas. We're having a devil of a time trying to dissolve it because it's a polymer at this point in time. And we look for a variety of ways trying to dissolve it just so that we could get the protein to work on it at that time. And that was decades and decades ago. And it's taken us this long to get this far. And I think the next 10 years, we're we're going to have a significant advancement in our understanding of it, especially since this is a variety of proteins that can accumulate. And each one of those may require different treatment as well as personalized treatment, as you said, because the protein may express or have different disease processes in different individuals based on other risk factors and genetics in them. So it's going to be a continual evolution, but it's certainly exciting at this time to finally have some way of identifying the disease more positively and of altering the outcomes for these individuals, which for many years had a very poor outcome without much that we could alter. I want to thank you for that. We're going to now at 1 o'clock move to the next stage. I would like to let everyone know that if they want CME credit for this, go on to the chat line and you'll see the how to enter to get your CME credits for that. The actual link is shown in your chat line for that. So let's move on right now to the next part, step 2 of this. Dr. Grogan was very informative in showing us how to diagnose this disease, the pathophysiology of it, as well as the treatment capability for this disease. So we have, for these new therapies, relative safety, I would say, and efficacy of this. So the last question is, what is the cost of this? Because if it's not affordable to our patients, then unfortunately this treatment, as good as it is, may not be applicable to helping those individuals. So we're going to discuss cost effectiveness of therapy. And for disclosures here, later today, we're going to talk about vaccines. So I put down for disclosures that the University of California, Davis is doing a large trial with Pfizer on vaccines for COVID-19. So that is the disclosures. So Megan, I don't see my last set of slides. Do you have my last set of slides that you can show? Or if not, why don't you just turn it over to my screen and I'll bring up my slides for it. Megan, just let me know. Is that the second set B for my slides? Megan,
this is the slide deck you sent this morning.
Okay, good. All right. Yes. All right. So just, okay. So let's go to the first slide or next slide. So the therapy for amyloidosis that you well described is available for AL patients. It's available for those who have the inflammatory type of amyloidosis, which we sometimes see with rheumatoid arthritis treatments, more rare right now. And in the past, AL required, as we can see, chemotherapy and stem cell transplants as the therapy. The TTR, or the transthyretin amyloid, which is shown, has had a couple of therapies. It used to be we had to replace the heart or the liver for it. In this case, we do have, as Dr. Grogan said, diflunisal is available for both cardiac and neuropathic wild-type TTR. Tafamidis is the new drug for cardiac, which came out from studies last year. Patisiran and inotersen for neuropathy, TTR, and then there are trials in place. On the right is an actual biopsy from the heart of an individual with wild-type TTR. And what you see is the darker purple is the actual myocytes. Now, those should be all packed closely together, as this would be a cardiac muscle biopsy. The pink areas that you see is the actual infiltration and deposition of the fibrils of amyloid. And you can see why this type of a heart with all of this infiltrated material and fibrotic type looking stuff is going to give you diastolic problems. It's not going to be able to relax as well. It's going to be a stiffer heart. And that's why these individuals with preserved ejection fraction even get heart failure symptoms with it. And obviously, with all of this infiltration, it's going to take time to get this to leave the heart and to improve function with it. So it's no question that it's going to contribute with big infiltration, both diastolic and systolic heart failure problems. Next slide. So as was seen earlier, these are these are not the actual slides I had recently sent to you. But anyways, do you have, Megan, the most recent slides that I sent you? They were sent this morning or not?
Yes,
If not,
this,
yeah, this is not it. This is, let me go to my, I'm going to actually pull up for you. And if you can share screen with me, I will pull up my slides. Sorry about that. And let's see.
While Bill pulls up his slides, I'd like to ask Dr. Grogan a question, and that is, are there implications for Alzheimer's? That's how we normally hear about amyloid.
That's a great question. It's felt that many cases of Alzheimer's may be due to amyloid deposition, but it's a different type of protein than the type that causes cardiac amyloid. So our patients with AL, TTR, or even AA, or the other ones involving the heart, or those other types of amyloid, do not have an increased risk of Alzheimer's disease. Great question.
All right, I am going to share content and start broadcast. And go on. All right, can you see that slide?
We can, yes.
Okay, great. So
Next
that
slide, please.
starting slide. That's why I said this is the most recent deck, and so I will then advance to the next one. We went over that, and so this is the third slide. And what we have shown on the left is the types of amyloid, but only focusing on the two types that Dr. Grogan talked about. First of all, on the top, the light chain amyloidosis. Here are the treatments that are outlined for it, for light chain, both reducing the production of it, as we talked about, removing the light chain deposits, and then inhibition of the fibril formation that occurs with AL. And there's various treatments that modalities that are listed there for treatment of AL. Transthyretin amyloidosis shown on the bottom has other therapies that you can see that reduce the synthesis or inhibit the synthesis of it. And as Martha said, maybe 90% of the synthesis can be reduced by these two drugs that are seen there. In addition, the therapy for cardiac involves stabilization of the tetramer. So the tetramer is stabilized so that it doesn't misfold and then get assembled in different monomers that then form fibrin sheaths or amyloid sheaths at that time. So the treatments for those are there, as well as newer treatments which might allow us to remove some of this protein from the heart. So we have a great way of treating it, multiple agents shown on the left. On the right, we're going to talk about cost effectiveness. So for AL amyloid, shown on the top, there are treatments, doxycycline at $1 a pill, all the way up to Venclexta, which is $116 a pill. So what we see for AL, there's a 100-fold difference in the price of a one-day pill for that medicine. On the bottom is for amyloid or cardiac amyloid. And we talked about diflunisal. That's about $1 a day as well for that therapy, $30 a month, versus the more advanced or recently released medicines, which are shown for tafamidis, which is literally 100 times or more expensive than the cheapest therapy. So what we see is a wide variety for this, with differences in price of 100-fold or more between the lowest cost and the highest cost therapy. Next slide. I'm sorry, I'm doing the next slide. Okay, so diflunisal, which we mentioned earlier, has not really been studied for amyloid in a retrospective, prospective, randomized control trial. The data shown here from the trials is really data that is more retrospective, but has encouraging results. As we look at the black box on the mid-right, we see that the hazard ratio for survival is 0.2. So we have almost an 80% reduction in the mortality associated with those individuals retrospectively who are on diflunisal versus on placebo in those trials, or not on diflunisal. So that's a really effective improvement in survival, hazard ratio 0.2, as well as an improvement in ejection fraction was seen in those individuals as well. And importantly, this therapy with big numbers like this, again, cost an average of about $1 a day for those individuals, or $32 a month as shown on the GoodRx price seen on the bottom. So discounts down to about $1 a day for this therapy. The next slide is therapy for the FDA approved tafamidis, which was, as Dr. Grogan said, used in the trial, randomized clinical trial, very good data. And circled on the top in red is the absolute risk reduction for mortality in this group. And as you can see, the 13+% absolute risk reduction yields a number needed to treat, as Dr. Grogan said, of 7.5, meaning you treat 7 or 8 patients with this and you will save 1 life or delay 1 death in this particular situation. These are very good numbers for cardiology. If we had all of our medicines being number needed to treat is 7 or 8, we would be delighted. Typically in cardiology, number needed to treat is somewhere around 50 for the therapies that we have currently for heart failure, diabetes, and other medicines. So this is very, very positive information for survival. On the right, we see that there is also improvement in symptoms on the lower right. That is improvement in symptoms in those individuals. And on the top, increase in the distance of a 6-minute walk, which is an objective way of looking how symptomatic these individuals are. Now, I show these curves because on the left, the survival benefit for tafamidis doesn't really begin until after the first year. So in the first year, there's not really a difference in the curves. It really splits out after about 18 months of therapy. So you need to be on it for longer than a year to get a survival benefit. The symptoms, however, seem to be improving at about 6 months, and those 2 curves on the right show a separation after 6 months. So this is a very effective drug, number needed to treat 7.5 to save one life, and symptom relief starting within 6 months of therapy with this medicine. No question about that. And safety was pretty good in this trial as well. Now, tafamidis versus our other heart failure medicines, and I use our most recent development in heart failure, which was sacubitril and valsartan combination. The number or the quality of life improvement with that for sacubitril, well used in our heart failure clinics today, shown on the bottom, that gave an average of 0.6 quality of life years saved for a patient's lifetime, for which it's been fairly widely adopted in our heart failure clinics. An extra 0.62 quality of life years saved for a heart failure patient is still worthy of consideration. But tafamidis compared, it's shown on the top, is more than double that at 1.29 years quality of life years saved. So this is not just an additional agent available for heart failure. It's an agent that is very effective, even more effective than some of our other heart failure medicines in the right patient, obviously. So very effective, number needed to treat 7.5. If we look on the left side, this is a cost analysis trial. You can see that the upper curves in blue are those on treatment for tafamidis versus red, those not on therapy. And they were able to project out over a couple of years what the cost would be for those individuals, the incremental cost of additional life saved. And we have that on the right. And what we can see is on the bottom of the curve is the annual cost of tafamidis, which in the US today is quoted at $225,000 per year per patient, versus the cost effectiveness, which is shown on the vertical scale, suggesting the circle in red is that it's about $880,000 per additional cost of life saved with this agent. Now, I mention that because in cardiology, we typically look at cost of life years saved as about $50,000 to $100,000 is what is affordable to our healthcare system and to our patients. So this comes in quite a bit higher than the $50,000 to $100,000 line, which are shown as the small triangle and box at the left-hand side of this plot. This is, for cardiology, our most expensive medicine that we have had ever since I remember practicing cardiology. So it's a big step up. If you remember PCSK9s, those individuals, those patients, we were a little bit shocked when they came out at $15,000 a year. Now we're looking at literally almost 10 times that at $225,000 a year per life year saved. So tafamidis is clearly a very effective agent with 1.29 additional years of life for it, but at the incremental cost of $880,000 for that extra year of life that you get. Now, if we were to reduce it to the typical $100,000 a life year saved, then we would expect the price would need to be reduced from $200,000 a year down to about $16,000 a year to make it in line with some of our other products. So terribly effective drug, relatively well tolerated in those individuals. But there are obviously individuals in Medicare where it is not affordable to them. So safe, effective, but sometimes unaffordable to the patients in that situation. If we look at the other drugs for amyloid, we were shocked at $225,000, but inotersen and patisiran are close to $500,000 per year for those individuals, even with a discounted price, net price of $345,000 a year. They're well over our cost of efficacy rates that we're used to in cardiology for it. And again, in this estimate, it was decided that they would need to come down by tenfold or more to make them cost effective in the usual realm that we're dealing with in cardiology. Now, these are the list prices. This is what you see and your patients may see, and it's available on the internet. The annual cost of the drugs, however, is changing. The first box on the bottom shows you that there are value-based contracts for therapy for patisiran that unfortunately are not available to you. I can't show you because I don't have those contracts. They are confidential. And you can see in the next box that one of the manufacturers did a confidential price cut with Nice in Europe to get it on the formulary over there. So none of this information, unfortunately, I can share with you because it is not publicly available at this time. So a lot of these deals are made under the table and we don't really know what they represent. So therapy for individuals is also complicated because Medicare requires the co-payments to be based on the list price of the drug and not the discounts and many commercial patients can get. So Medicare patients do have to pay a specific percentage, both in the donut hole and out of it, for the drug price based on a calculation, and that cannot change at that time. Unfortunately, with even a 5% copay or something like that, there may be tens of thousands of dollars out-of-pocket costs for your patient, which for some individuals may make it not affordable for those individuals, especially since amyloid, both AL and the ATTR wild type, do frequent the older population. So many of our patients are, in fact, the older population for that. So what we see is that obviously great drugs, safe, efficacious, but could be unaffordable. Now, where is that in our clinics? So in our clinics, we spend a lot of time on trying to get pre-authorization, which is required for all of these through. But it's still a problem for Medicare. And that's realized by the company as well as our medical programs. And you can see here the headline that Pfizer has gone to court to declare the Medicare ban on not allowing discounts to be unconstitutional. And so that this question is now in courts, and the bottom two boxes in dark show that the claim is that the Medicare policy of not allowing discounts and to charge a percentage of the list price is claimed to be a violation of the First Amendment, your First Amendment, and your Fifth Amendment for that. So this case is now in court. So I cannot answer how this is going to roll in the court systems of the US, and whether this represents a First or Fifth Amendment violation of the Constitution. That's going to be decided by the courts, and I am not able to tell you how the courts are going to decide on that at this time. So what do we do for now? So what do we do for now is we do recommend these medicines. We try to get our patients on the best medicines, And for cardiac amyloid, tafamidis in the right patient who has cardiac amyloid, ATTR, is very effective, and we try to get them on it. It requires pre-authorization. We now have had to establish at our hospital a group of individuals, nurses who work hard to get through the pre-authorization. There's paperwork, there's submissions, there's appeals, there's other things to get it through. Our group of nurses works very hard to do that, and pharmacists to do that. And they are able to get literally 90% of those that we want on this drug actually on it so that they can take it. So 10% can't afford the copay no matter how we work it, but 90% can. So if your healthcare system has a dedicated group of individuals willing to do the paperwork, and realize this is an entirely add-on to the costs of our clinic to establish to get this through, then you will be successful in about 90% of cases. So our successful nurses are shown on the left. They use a variety of ways to try to get the best price for their patient, and they are off and usually effective in doing that. And we certainly want to thank them and appreciate their time for doing that. And so in summary here, you can see for amyloid, your body has to know correctly how to fold the protein. If it's not folded, it's going to build up and give you a problem for it. To effectively reduce that, it's important that you take the correct medicines for it. And the best medicines is going to require you to wheel and deal to get the price for your particular patient so that they can afford it. And I can't tell you what that price is up front because I've made multiple calls to try to get it. It's variable at this point in time, and it really depends on when you process it through with either a dummy script or a real script before the patient winds up. And not all of my patients I can actually find out what they're paying, because that's not determined until they actually go to the pharmacy to get it at that point in time. So in the end, we do have successful medicines. They are effective, but in the end, you'll have to or not know what the price is until the dealing is done. And the dealing is going to be done not necessarily by you or your patients, but by others until you find out.
Thank you, Bill. I think this has been just an absolutely fantastic day of learning about cardiac amyloidosis. We are having a little bit of a technical issue with Megan Olson, our operations lead, having been kicked out of the Zoom meeting. So she is not able, okay, she's rejoining us. And in order to get Dr. Kaplan's bio up on the screen, it might take her a couple minutes, but I can certainly introduce my dear friend and colleague of many, many years, Dr. Robert Kaplan, the author of more publications than one can count. And Dr. Bommer, would you like to formally introduce Dr. Kaplan? I see that we did for a moment have his bio.
There we have it. Sure. So Bob has been a great friend and a great help to the Right Care Initiative. He brings science, he brings information, and a real passion for helping individuals. He is actually a founding co-leader of the Right Care Initiative in the years before, and serves on the expert group for the program. He is the former chief officer of U.S. Health Services and former director of the NIH. So he is currently staying at Stanford, where he's a distinguished research professor of health and medicine at UCLA, where he was down there before. He was chair of health services for a period of time, went through different areas, and he is currently a faculty member at Stanford School of Medicine and Clinical Excellence Research Center. And we're delighted today to have Robert talk about the situation we're in the current pandemic. And Robert, we're delighted to have you lead us in this exploratory discussion of how do we get out of this pandemic.
Thank you, Bill. I really appreciate it. Megan, if you could stop sharing, I'll go ahead and share my screen, which I think is probably the easiest way to do this. Oops.
This is a feature of Zoom that we haven't become expert at, but we're working on it. So thank you for your patience, everyone.
Okay, so.
Good.
It's going to take a minute here. There we go. So what do you see?
We're all set.
Policy.
We got
That's
your first slide.
Great. So thank you. And thank you, Hattie. Thank you, Bill. It's a pleasure to be with you. I'm going to race through a bunch of things relatively quickly today, and so that hopefully we'll have a little bit of time to discuss this. And I have to apologize in advance because there's likely to be some typos. I think many of you know that this is NIH grant writing season. And so we have a whole bunch of deadlines, and I was making slides this morning, and so it's possible that they will be imperfect. So let me begin by saying that one of the things that my many years in academia have taught me is that science brings with it a lot of humility, and that we learn frequently that we can be very excited about an idea, we think we understand mechanisms, but then we later learn that in fact we've been misled. And I think that's part of the excitement of being involved with science. So humility leads us to happiness because it makes you more teachable. I want to just take a couple minutes to mention a paper that's not out yet. It's in press that comes from my Stanford colleague, John Ioannidis, who does a good job of helping us become skeptical about things. But one of the things that John points out is that we actually have been wrong a lot as we make predictions about what's happening in the coronavirus epidemic. And so, for example, last spring, there was some discussion about what was likely to happen if Georgia opened its businesses too soon, specifically on April 27th. And that they predicted that there would be an excess of about 23,000 deaths. But in fact, there were only a couple hundred deaths. Similarly, the Massachusetts General Hospital had privately held discussions about what was likely to happen over the course of a couple of weeks leading up to about June 1st. And they estimated there would be about 3,000 deaths, but it turned out that there were only about 12,000 deaths, and that there were only about 3,000. Or the Wharton School of Business created a model. And in that model, they argued that there would be about 233,000 excess deaths from the coronavirus in the United States. But in fact, it turned out to be about a third of that. Still terrible, but in fact, the models got it wrong in many cases. And in the Ioannidis paper, he looks at this situation where he takes the four most common models, and then he estimates how often these models were correct. And so what you see is the four different models, and then he looks at how often the models were within about 10% of being right. So confidence interval about 10% either way in predicting deaths. And these are deaths that are fairly close at hand. And if it's dark blue or purple, that means that they were right 0% of the time. And then if they're red, that means they're right about 40% of the time. And you can see that the models perform quite poorly. And in fact, there's been a lot of confusion as the epidemic has risen and fallen. What does it mean when the number of deaths goes down, but you have to project into the future as to what's going to happen in the next phase? And what happens in these analyses is that, in fact, models predict all sorts of things. And so the models are supposed to be forecasting the future, but in fact, often they make such different predictions that it's not of much value to policymakers. So for example, these models predicting what's going to happen out several weeks after this curve is declining range from about 2,400 deaths to about 11,000 deaths. So it's a difference of about 4.5-fold. And I just wanted to point out that there are some adverse effects of getting the modeling wrong. So for example, effective treatments for major conditions like coronary heart disease and cancer can be delayed. To make way for the surge, we know that thousands of COVID-19 infected patients were sent out of acute care hospitals into nursing homes where they put themselves and others at greater risk. We know that MI and stroke patients did not come into the hospital when they had acute onset symptoms because they were afraid to. And we know that the slowdown in services caused fairly serious financial strain to hospitals. Not to mention what happened with the reconstruction of a lot of facilities within hospitals. So for example, at Stanford, by the way, I think that the hospitals did exactly the right thing. I don't want to sound as though I'm critical of them. I think the hospitals did a great job of doing the best they could to predict what would happen. But just as an example, at Stanford, Stanford has a brand new $1 billion hospital. And what happened was that they completely turned it upside down because of an expected surge in COVID patients. And so an ICU, I think that had a capacity of about 75 beds was turned into one with a capacity of 225 beds at an enormous cost. Yet that surge never really happened. And again, they had to have done it this way. But the point I wanted to make is, could we do it better? And what can we learn from the experience that we encountered? So our former United States Secretary of Defense, Donald Rumsfeld, said, there are known knowns, but there are also unknown unknowns. And that the ones we don't know, And the ones that look if we look throughout our history, blah, blah, blah. So what remains unknown? And I want to make the argument that many of the statistics that we need to know still remain unknown. So for example, how many people are infected? And I'm going to argue that in fact, we don't know that. How many people have died? We still have some uncertainty around that. What's the value of tests? Somewhat unknown. What's the effectiveness of treatments? Still largely unknown. And what's the potential of a vaccine to end the epidemic? Not known yet. And what's the public acceptance of vaccines? Well, that we know a little bit more about, and I'm afraid that it's low for a variety of reasons that I'm going to mention. So first, let's take on this issue. How many people are infected? It seems like we should know that. So as of today, October 12th, if you go to a variety of different websites, the numbers differ a little bit by the method that's used, but the argument is that there's 7.7 million cases, and there have been about 215,000 deaths in the United States, a very disturbing number. So that gives us a case fatality rate of 2.8%. So you just divide the 215,000 deaths by the 7.7 million cases. But this number is completely dependent on the number of tests that were given, because you can only become a case if you've been tested. And we know that many of the people who are infected are likely never to have received a test. So the more testing we do, we're likely to decrease the case fatality rate. So you'll see that a lot of people are reporting that the case fatality rate is declining. And that may be because that the number of deaths is really declining, but it also may be that the denominator has changed, an issue I'm going to get back to in just a minute. So over the course of the last 6 months or so, I've gotten into a new business, which is to become an opinion writer. And so I've been doing a lot of small studies and op-ed writing for publications that I haven't really involved myself with in the past, partly because that our system of academic publications has proven to be pretty inadequate for rapidly moving science. And so we have to find outlets of publication where we can get information out much more quickly than going through the traditional peer review system. And of course, that has a lot of problems, and hopefully we can come back to discuss that. But one of the big issues is, well, how many people are infected or how many people have been infected? And I think, of all of you know, there's different types of tests. There's PCR tests that determine who is currently infected. There are antigen tests, which have a similar purpose. And then there are antibody tests, which allow us to estimate how many people have been infected, or at least how many people carry B-cell antibodies. And when we looked through a variety of these evaluations that you can get at several different places in the published and unpublished literature, we find that the seroprevalence rate, that is the number of people that appear to have been infected in our population, varies dramatically. And again, a meta-analysis done by John Ioannidis shows that the rate ranges from 0.1%, about 1 per thousand, to 48%, almost half the population. Now, we have several seroprevalence studies that are in play. And so Stanford has one that's coming along. The data were collected in July of this year. And then the CDC is doing a study, the NIH is also doing a study. And it's starting to settle out at a seroprevalence rate of about 9%. So that several estimates suggest that about 9% of the US population may have been infected, or at least carry the antibodies. That could be cross-reactivity to a previous coronavirus, but it may be in that range. A separate methodology looks at dialysis patients who, of course, have where there's access to blood on a regular basis. And it appears that among dialysis patients, it is about 8%. So one of the next issues is, well, how good are tests? Because when we heard early on in the epidemic that the solution to this problem was testing, testing, and more testing. And one of the arguments that I hate to make, because that it is somewhat of a disturbing finding, is that testing may not be doing what it's supposed to be doing. And I'm going to sort of talk about that in a little bit more detail. But one of the things that we do know is that a lot of the tests that are out there are not dependable. So for example, as antibody tests became available, the FDA decided to allow emergency use authorization to just about anything that applied. And so in a very rapid period of time, they approved over 300 separate antibody tests. And as these tests got released out into the market, and there was testing on the testing, that is formal evaluations, it turned out that many of these antibody tests turned out to be almost completely worthless. And the FDA was required to pull them back, and pull them back relatively rapidly. So I did a piece for The Hill, which is a Washington, D.C. publication, with a woman who runs one of the FDA watchdog organizations. And we had access to a lot of this data, really, really quite surprising. One of the other issues is, well, how many people have died? Well, it turns out that some people argue that there's an overcount. In other words, they argue that that people who have died of other causes were older and sicker, and although they might have been COVID positive, the likelihood of their survival in the short term was very low. And so they argue that counting them as COVID-19 deaths was inappropriate, and it inflated the number. And people sometimes claim the number was inflated for political purposes. Another issue is that if a person has tested positive and they died of another cause in very short order, that is, someone with very advanced pulmonary or cardiac disease who had a very short life expectancy, has that death attributed to COVID-19 if they test positive. There also are problems because we know that different countries and different states actually have different ways, different reporting standards and methods. And so we know that in some states in the United States, for example, that even accidents and suicide deaths get counted as COVID-19 deaths, even though no one knew that the patient was positive for COVID-19 during their lifetime. So that's the overcount. On the other hand, there's evidence that there's an undercount. And the undercount misses people who died before testing was available, that there were deaths that were indirectly linked to COVID-19, such as failing to seek medical care, which we know happens. We mentioned that earlier. People that may be having an acute stroke or an acute MI don't go in to get effective treatment, and they may die because that they didn't get treatment for those conditions, even though they were never diagnosed as having COVID-19. Overall, having looked at this literature recently, I think that the undercount is more persuasive. And this has been studied in a variety of different ways by looking at the expected deaths from year to year, and then looking at the excess deaths this year. So assuming that everything else is equal, how many deaths are added to the normal death rate? And it does appear that there are several 100,000 deaths that are attributed, that have increased this year, most likely because that we're just adding new deaths because of COVID-19. And a recent paper, although it's not out yet, but a recent preprint suggests that there may be about 36 additional deaths for each 100. So it's quite a substantial increase. And this varies by geographic location in the United States. So if you go from place to place in the United States, it seems to be more common in the South and in the Midwest than it is on the West Coast and the East Coast. So the next issue is that we assume that tests tell us the truth. So we assume that if you have a positive test, that means you're effective, and that if you have a negative test, that means that you're uninfected. But in fact, we know that's not exactly right. So for example, the LI Unified School District is engaging in a program where they want to test all of their students, which is about 700,000 students, and that they want to test, in addition to that, their 75,000 employees. So recently with Michael Hockman at USC, we had an opportunity to kind of look into this. This is an expenditure for the LA Unified School District of about $200 million per year. And the question is this the best way? And certainly that you have to applaud the school district for making a serious investment in keeping their students and employees safe. But is this the best way to use that $200 million? So a couple of months back with an infectious disease epidemiologist and infectious disease physician and a rheumatologist, Mike Wiseman at Cedars, we looked at this question: does it make sense to test everybody repeatedly? And it turns out that clinical physicians, like my two co-authors on this, and me, public health scientists, actually come to different conclusions about the best way to do this. So clinical physicians like the idea of testing everyone to make a clinical diagnosis and to identify who should be treated. On the other hand, treatments don't work that well. So as where we are, unfortunately, in the pandemic is that the treatments that we have, even the ones that have been successful in clinical trials, have only very modest effects. Where on the public health side, our argument is that we really need to understand the dynamics of disease transmission in communities. So what we really need to know is how many people have prevalent disease and how many people have incident disease. In other words, how many people are transitioning into this condition. And we need this so that we can make better plans. No, we're not opposed to a clinical evaluation, but we think that a significant portion of the resources should be used to monitor where the pandemic is and where it's going. So if you go to the LA Unified School District, you make the assumptions that it's a good test. So the meta-analysis of the COVID-19 test showed that it has on average a sensitivity of about 70%, meaning that about 30% of the negative tests are false negatives. So there are some people who actually have the illness, but they test negative. And the sensitivity is good, it's about 97%. But the real problem is that the prevalence is low. And by the way, that's not a problem, it's a good thing. But in terms of evaluating the test, low prevalence means that the test can give you misleading results for the population. So when we simulate this, the positive predictive value, meaning that what's the likelihood that you have the disease given that you test positive, is only about 0.1. In other words, only about 10% of the people that test positive actually are positive. And so the ratio of false positives to true positives is about 8 to 10 to 1. So in the LA Unified School District example, that the tests are rated as really good. And so when we talk about, is this an accurate test? The test is, if it's the PCR test, it's about 98.6% accurate. So among these 775,000 students and staff who get tested, there's going to be about close to 44,000 people who will have positive results. But that among these, only about 12%, according to our simulation, are actually going to be infected, and nearly 88% of those are going to be given positive results, and they might be quarantined, even though the test results are probably incorrect. By the way, when I did this simulation, I was certain it was wrong because it just seemed too far off, and I sent it around to a variety of other testing experts around the country, and that we all pretty much came to the same conclusion using slightly different calculation methods. So that most of the LAUSD tests, it's about 731,000 of them, are going to be negative. And among these, the negatives are going to be right 99.7% of the time. So what this tells us is negative test results should be reassuring. Although they're imperfect, negative test results almost always are right. But positive test results are almost always wrong. And again, we can come back to this in the discussion, but it's a really challenging issue. By the way, if you just think about it this way, at least 99.5% of the people in the population are not infected. So if you were just to close your eyes and never really send the samples in to go through the laboratory, and you said everybody's negative, you're going to be right 99.5% of the time, which makes this so confusing. So the last couple minutes, I want to just talk about another twist that we've put on this, because in addition to doing the other work at Stanford, we've gotten into the public polling business. And this has been really fascinating to me. We have contracted with an organization called U.gov, and YouGov does national polls, and we have been doing repeated studies of about 1,000 U.S. adults. And we completed the first round just before Memorial Day, and we completed a second round just before Labor Day. And it's a really interesting methodology that we use sample weights that make it almost exactly representative of the US population, and we're able to validate it. So we asked people, for example, who they voted for in the 2016 presidential election. And actually the numbers who voted for Trump and Clinton almost exactly match the real votes. And so we are interested in validating them against these verifiable events. So one of the findings, which we had a little piece in the LA Times about last week, or about 2 weeks ago, I guess, is we just asked people as part of this survey that if a vaccine for coronavirus was available without charge today, how likely would you be to take it? And much to our chagrin, only 39% of this representative population of the US said they would be very likely to take a vaccine if it was available today. And another 28% said they'd be somewhat likely. But 20%, 1 in 5 Americans, said that they were unlikely to take it under any circumstance. And 36% of the respondents, over a third of all the people in the survey, believe that there are harmful effects of vaccines that the government is hiding from the public. Arnie Milstein and I have another piece where, using the same survey data, that we realized that about 39% said that they were very likely to take the vaccine if it was 90% effective. So that's good. But if the vaccine was less than 100% effective, or less than 90% effective, if we told the people, well, what if it was only 50% effective? Then it drops quite considerably, by about 25 points. By the way, minor side effects don't affect people much, but that the estimated, the average effectiveness of the flu vaccine in the average flu year is about 50%, and that the FDA is saying that the threshold for licensing is going to be 50%, but the confidence interval goes way down to 30%. So what we did discover in these public opinion polls is that it's become very political. And here's sort of a cute thing that we did, which is a little experiment within the big study. We said, if President Trump assured the public that the coronavirus vaccine was safe and effective, how likely is it that you would be vaccinated? And it turned out 18% said that they would be likely to be vaccinated if promoted the vaccine. But then so half the respondents got that. The other half got exactly the same question, but we substituted the name Dr. Anthony Fauci for President Trump. And when we did that, it jumped all the way to 46%. So who endorses it, unfortunately, in our current political climate, has a significant impact on whether or not people are likely to take the vaccine. Another thing that we've been doing, I had a piece with one of our fellows a couple months ago, and also my colleague, Kevin Manton, has been working on something similar to this, where we look at countries that have done well in comparison to countries like ours that have done less well. And there are examples out there of countries that have really done quite remarkably well in dealing with the coronavirus outbreak. Germany, for example, has a 0.3 case rate. Their deaths are about 11 per 100,000 in the population. China, Singapore, done great. Thailand has a 0.8 per 100,000 in the population death rate. And New Zealand, the real success story, has a death rate that's only about 0.5 per 100,000. So how did they do it? Well, they did it primarily through traditional behavioral intervention, social distancing. They have policies for universal mask use. They have limitations in public gatherings, and they have coordinated public policies. So this is just too complicated, except for to say that there was a study that just came out in the BMJ where they looked at what's happening in 149 different countries. And it looks something like this, that countries that have more policies and more sort of formal distancing policies do better. And the policies that have worked are school closures, workplace closures, restrictions on mass gatherings. Public transport closures had a smaller effects, but work lockdowns. And I know this is very disturbing news to a lot of people who are quite eager, like me, to get back to our ordinary way of life. But in fact, just looking at the data from across countries, it seems to go in this direction. So what's happening now? Well, one of the things that's happening now is that there is unusual pressure on federal agencies to speed up the process. And, again, this is my opinion, and so take it for that. But terms like warp speed bothers me because that I am as eager as anybody else is to have a vaccine. On the other hand, that vaccines, as we know from previous experience, can be risky. And so President Trump has announced that he would like to have a coronavirus vaccine given emergency use authorization prior to the November 3rd election. But we know for sure that there'll be no phase 3 clinical trial that will have reported results by that time. But the FDA has just announced that there is going to be a special FDA review from the Vaccines and Biologics Committee that's going to meet on October 22nd to consider emergency use authorization. And I actually have been invited to testify at that hearing, and I'm looking forward to doing that. So what do we do? Well, first, I think that we need a coordinated national policy. That's what we see in the countries that have done much better in fending off the epidemic. Secondly, we need national policies on testing, including standardization of measures. There's no reason that we should have now 400 to 500 different measures, often not well synchronized with one another. We need to coordinate local, state, and federal responses to this pandemic. And again, this is a problem that we've had in public health for decades, that we have public health departments in counties that don't coordinate their activities well with what goes on in states. And we have state health departments that don't coordinate their activities that well with the CDC and the federal authorities. And this is a problem that as we exit the pandemic, we really need to address. And finally, we need to maintain standards for the approval of medicines and tests. And again, as I said earlier, I'm just as eager as anybody else to have an effective vaccine and so forth. But there will be serious consequences, I believe, of rushing this too quickly. So as a way of wrapping this down, thanks again for having me, Hattie, and the others. It's always a pleasure to be part of Right Care. So let me just conclude with some advice. Stay skeptical, my friends, and thanks for having me. Hattie, you're on mute.
Thank you, Bob. That was really a wonderful presentation, and I couldn't agree with you more.
Thank you, Bob. It will be interesting to see if we can put some of this information to use. I liken it to predicting where a hurricane will hit, and actually with a lot of variables in it as well. We've gotten very well at predicting, at least over the short term, the actual landfall for a hurricane. Do you think as we get or garner more information, our prediction of this will dramatically improve?
Thanks for the question, Bill. I do think it's going to improve. So again, I think things are getting better, and it's like anything else that as humans, we do better when we have more experience, and it's been a heroic effort. We've come a tremendous distance in a relatively short period of time. On the other hand, and people keep pointing out that vaccines are developed over the course of a very long period of time. As you know, in medicine, new therapeutic agents don't usually just spring up, that it takes a long time to test them and to adjust them and to learn how to apply them in clinical practice. And we have really sped it up for this pandemic, which is terrific, but the expectation that things can be done so quickly, I think, is unrealistic. We will get there. I'm confident we'll get there, but I do think it's going to take a little bit of time to get through it.
Could you possibly comment, Bob, on the comparison to the 1918 flu and what you would anticipate from your long view we may be facing?
So, Hattie, it's a really good question. And first of all, I think that the 1918 flu is helpful. But I think that people thought of it as the playbook. And so for a variety of different reasons. One is that, of course, molecular biology hadn't been invented then. In fact, in 1918, people were still, filtering sputum through cloth to try to determine if you capture bacteria, to separate bacteria from something else, which they assumed were viruses. it was an epidemic primarily of young people, although it affected people of different ages, but it primarily started out with military people, and it was the flu. And so there are some things to learn, but it being the exact playbook, I think is not realistic. By the way, I think our capacity, because of that our tools are so much better than they were 100 years ago, our capacity to learn and move quickly is much better than it was back then. But it's helpful, but not the guidepost.
So one more question. What I like to follow most closely is the death rate per hospitalization, because those are people we know have it. It's a more secure sample. Could you just talk a bit more about that and whether you're seeing it improving?
So it's improving, and again, you have to get into the specific hospital data, and that there are databases that you can look at that will show that in various places. So we were really doing great a few weeks ago, where several of the hospitals that we look at, they had rates that were declining and continuing to decline. There has been a little bit of upswing in the last few weeks, and that these bumps in the road are to be expected. So again, like a lot of things in clinical medicine, although that there, the number of therapeutic agents that are available are limited, but I think that good clinicians get better at what they do, and I think it reflects some of that. I think it reflects the dynamics of the epidemic changing a little bit, and we'll have to see. So the number of people in acute care facilities is declining.
Bill, could you talk just a little bit about what you've seen in terms of the different genetic strains or the different, really different strains of the disease in different geographies?
So, other people may be better able to comment on that than I have. I've looked at that literature a little bit, and there, so viruses mutate. I mean, sort of the history of viruses is that they mutate, but this one has mutated less so than it was anticipated at first. And so there is some evidence, of distinct mutations that people have been able to follow and characterize with PCR and so forth. But I don't know if anybody else on the phone has followed this literature carefully. It's very interesting.
Chairman Bommer certainly has.
So yeah, it is fascinating, obviously, to deal with any new entity. Certainly this is a novel one, as we all know. When we had the first community acquired case in the US. So we got the first patient February 19th, who was transferred to us with acute respiratory failure on a ventilator, not doing well. And we actually were not able to get a test because the CDC did not allow us to use the test for 5 or 6 days. When we were finally allowed, it came back positive with the CDC testing kit for COVID-19. And we took the virus from that particular patient and we coded it and sequenced the mRNA. And then we compared it with what sequences were reported from China, from Wuhan, from Seattle, from Washington, from the Princess Cruise Line, from Italy, and from New York at the time. Well, we were able to document that there's at least 140 to 150 mutations in the virus sequence so far. Those we were looking at whether they would make the virus more infectious or more deadly, et cetera. We're still looking at that information. But it was interesting that those mutations allowed us to track and see where any particular infection came from, because you could track it back looking at the mutations. It turns out our virus on February 19th, first community acquired one recognized by CDC, did not come from the New York group. It did not come from the Seattle group or the Princess Cruise. It appears to have come in directly from Wuhan before the airline restrictions were in and there were travel restrictions for it. The virus does appear to have fewer mutations than, let's say, influenza, because there is actually a protein in there that code corrects and it reads the mRNA sequence. If there's an error in your cells in cloning or making that mRNA, it will actually correct for it at that time. That's a correction process that we have humans so that we get less cases of cancer. So we have actually a code correction capability. If we make a new DNA and there's a correction in it, we can actually error correct for it. So this virus is a little bit more advanced than influenza in its code correction capability with less corrections for it. But we do know that there's another problem with this virus. In some individuals will actually be infected their cells with two different strains of this virus. You can get both strains. And when two different strains are in the same cell and you're kicking out RNA, the RNA can recombine or can adjust to come out with a hybrid of that particular mRNA as it's released from the cell as new virons. So there is a way of sharing or let's say changing the actual code in the virus through recombination, not necessarily through mutation. The virus is pretty similar in most of the cases, less mutated than we will see. But it will be interesting to see how all of this goes. Bob, you mentioned the pandemic of 1917-18. That lasted a couple years without any vaccines at the time. So will this virus, you think, pan out and go away in a year or two and disappear? Or do you think there's a chance it will continue? I'm a little bit worried that if the vaccine comes out with 50% efficacy, and if only 50% of the people take it at that time, then we are not going to get as much herd immunity or protection as we anticipate. The other problem with this virus is, for our other coronaviruses, we've seen that immunity is not for life with this coronavirus group that we've looked at. And we do have at least 2 cases already of reinfection with COVID-19 in 2 individuals. And the concern would be, is this going to be like the common cold, where you sort of can get the same virus every year because your immune globulins are down and you're dependent on your cell processing or cell mediated response at that time?
Well, Bill, of course, this is a great question, and I wish we knew the answer to that to these issues. That you know, I spent some time recently. It was actually a very interesting journey reading about pandemics, and of course, there are lots of them. You know, so pandemics occur on you know, sporadic intervals, but it's in documentation of human history. It's been there for a long time. And typically they do go away. I mean, I read a little bit about the bubonic plague epidemic of 1347 to 1350 roughly, and that it was really genuinely terrible, where half of the people in Europe perished in some areas. But it went away, and that seems to be the most common thing that happens. On the other hand, there are epidemics, HIV being one, where it's with us forever, and you know, it's hard for us to assess exactly where that's going to go.
Well, Bob, one of the things that you covered was where we're going, et cetera. This is called SARS-CoV-2. It's the second SARS-CoV out. We know that in the bat population, in areas of southern China and the forests and others, there are hundreds, if not thousands, of these viruses circulating. What do we need to do, because this is not our first rodeo, to prevent the next pandemic? What steps do we need to take now to have a better reaction and avoidance or prevention of the next pandemic that is currently out there in the world today, but not yet in humans?
So a great question. So I mentioned earlier that I had done this piece with one of our fellows, Winnie Sung, who is a oncologist that spent a year with us from Hong Kong. And she and I started talking about questions like this. And it turns out that we looked at different countries that have fared well. And in particular, we looked at Germany, and then we looked at Hong Kong, Taiwan, and parts of China, and Singapore. And those countries did really well. And one of the interesting precursors of doing well was having had exposure to the original SARS or MERS epidemics. And that I don't think it's immunity. I think what happened was that countries that had that threat mobilized in a serious way to try to fend off the next epidemic. And so mask wearing, for example, became acceptable, social distancing and so forth. So to answer your question, what we do in my household is that we've come to the conclusion that it's not really testing. I think that the recent White House experience with the super spreader event gives you a sense of the limitations of testing. Everybody was tested. But what we do is that we assume that everybody else is infected. And so we wear masks and we socially distance, and that it doesn't really matter if the person that we pass on the street, if they've tested positive, we pretty much treat them the same way as people who we just cross paths with. And unfortunately, it's a crude way to deal with it, but I think that remains the best tool that we have available to us.
I see that we have another one of our co-chairs from Los Angeles, Steve Chen, joining us, and I'll bring him in just a moment. I read a very interesting article this weekend, which I would like to just pass by all the doctors that are on the phone with us or on the video call with us. And that is that there seems to be some enhanced immunity if you take the live flu virus or any vaccination, that there seems to be additional immunity conferred for all causes. And I wonder if anybody is familiar with that and would like to talk about, and Bob Kaplan first, the suggestion in this article was get the live flu vaccination this year because it might help protect you against COVID-19.
So it might, and others are better qualified to respond to this question than I am. But as Hattie, you've heard me say over the years that I'm very focused on outcomes as opposed to surrogate markers, and this is one of the controversies with the FDA. So, are you willing to give somebody emergency use authorization on the basis of a surrogate marker like antibodies or B-cell immunity and so forth? And that it's a compelling argument, but I would really have to see the data on whether or not that hypothesis bears fruit when it's evaluated in trials.
Thank you. So what's your recommendation on a flu shot? I have to say, like you, Bob, our family is completely isolating and treating all others as if they are infected and could kill us. So we're being extremely careful in isolating, mask wearing, etc. So I'm sort of feeling like, well, how could I get the flu? Aren't all the measures that I'm taking against coronavirus going to protect me against the flu? Should I even expose myself to the live flu vaccination when some people do have really bad reactions?
You know, again, so I'm a big believer in vaccines. So even though I'm somewhat of a skeptic about a lot of things, I'm a big believer in vaccines. You know, when we used to have the yellow card from the WHO when you traveled, my yellow card is all punched up. You know, I've had all the vaccines. And in general, I think that the safety efficacy profile on most vaccines is really quite good. And so I think it's a good idea to stay current with your vaccines. The issue is whether or not we know much about this vaccine, you know, the vaccines. By the way, I'm also confident there will be a vaccine for SARS-CoV-2. I think there will be, but that that it is really important to have the safety and efficacy data before you push it onto healthy people. And I know there's a wide range of opinions on this, but I think that most people kind of share my view. I don't know if the others on the call feel that way, but I do.
Yeah, I think we all share the idea that we'll be better off with vaccination, even if it's not completely protective, at least it will help. Bob, one of the things in your projection models would be if we implement or have implemented, and perhaps not completely, mask and social distancing for COVID-19, do you expect that perhaps this fall influenza transmission rates and infection rates will go down as well, because they might, or the influenza spread might be attenuated by masking, social distancing, and certainly we do have fewer kids in school?
So in the Southern Hemisphere, that seems to have happened over the winter, and their winter, and that very reasonable hypothesis that it's it's not going to be a bad flu year, and for the reasons you mentioned, Bill. In addition to that, nobody's getting on airplanes, and so part of the way that these influenza viruses move around is that they start in Asia, they move to the Southern Hemisphere when it's their winter, and then they come back with travelers. And so that it wouldn't be a big surprise actually if there was less flu this year. By the way, I wanted to make one more comment, if you'll indulge me, and that is, doing these public opinion surveys, one of the things that has been very bothersome is now in our sequences, what we're finding is that the people that are skeptical about taking vaccines is increasing, and it's been creeping up for a long time. And as you mentioned, Bill, that if you have 50% efficacy and you have 50% of the population taking it, so 0.5 times 0.5 is 0.25. So that gives you a quarter of the population that may be protected. And that means that we won't get to herd immunity, at least that way. And that's something that I think in a public policy perspective, we really need to be thinking about. How do we, as a country, best address that issue, given that we are likely at some point to get to a vaccine that does work well?
Certainly a concern. And then the other is access to the vaccine. There's been Steve is on board. Do you think that pharmacists will be able to give the vaccine and administer it throughout the country? Because one of the things we realize is access to healthcare may be somewhat limited, but I think Steve pointed out at one time that there was a pharmacy within a couple of miles of every individual in the United States.
Yeah, to be clear, there are 4 times more pharmacies than Starbucks across the nation. So yeah, they're everywhere, literally. So the short answer is the federal government has authorized pharmacists to give a vaccine when it becomes available. Bob, I really liked your talk today because it's pretty sobering, right? To realize that there's going to be this much resistance. I mean, in the pharmacy communities, everyone was talking about how we're going to have to give 660 million shots because everyone's going to need a shot. And, you know, I think we both realize, and all of us realize that the actual number, unless we can make an impact on policy and education, is going to be a lot less than that. Even this morning, I was on a subcommittee with USC task force that focuses on the vaccine challenges, and there's so many, right? There's also the fact that the mRNA vaccines all need to be deep frozen, and once you defrost them, you have to use them within 24 hours, or they can only stay good for 24 hours in the refrigerator. So lots of challenges on how we're going to do this, but Bill, to your point. We are going to be able to at least make them available through pharmacies if people show up.
So, Steve, do you have a minus 80-degree freezer right now available to you in your most of these outpatient areas?
No, but I probably know a supplier in China that can get some over here. No, that is the battle, right? It's a big scramble right now to acquire these, and that's going to create another supply problem, right? So, yeah, it's we'll see. I mean, there's you know, if J&J's product gets done, it's a one-time shot. It doesn't require a deep freeze. It's not mRNA, so it's a matter of, you know, what makes it to the end, right? We're all eager to see.
And with 7 billion people in the world, you know, and I don't know how many of them you have to vaccinate, but you know, that's a lot of glass that you have. And so there are some challenges.
Yep, absolutely.
Would you care to speak about some of the other therapies that are coming online that maybe people would be less afraid of, and that have been shown to be effective, such as the steroids? I mean, we are making some scientific progress, and we so appreciate our scientific community. They're ones that are going to save our society from, and our world from, devastation. Monoclonal antibodies, for instance, steroids, the intravenous medications that are being used, the antivirals.
You know, Hattie, and Steve is much better qualified to talk about this, but you know, I do worry about, first of all, we, you know, as I probably told you before, you know, we look at every new FDA approval. So we have an ongoing project where every time a new drug is approved, we go back and get the trials from clinicaltrials.gov. We look at the effect sizes and so forth, and that, you know, most of the therapies, although there's some that have statistically significant effects, there's small effect sizes, and so that's a concern. In addition to that, you know, Steve was mentioning the logistic challenges of you know, getting a vaccine that has to be stored at somewhere between -70 and -90, and how you work that out. But the logistic problem of having a huge pandemic where you have therapeutic agents that require infusions is mind-boggling. And again, you know, with monoclonal antibodies and so forth, that we just don't have the capacity that I'm aware of to really administer those to hundreds of thousands of people.
Yeah, sorry, Hattie, I have to agree. It would be great to have a discussion, say, hey, we're about to have the next Tamiflu for COVID, but that's really not here. And I think Bob's absolutely correct. Even once it gets here, the supply issues pretty daunting. I mean, we saw for ourselves from Regeneron, a product, an antibody that seems to have some promise, right? It was used for the president. It was used for the president. I think he's the only one that can get it right now. So there's not a lot of, other than what you mentioned, Hattie, you already mentioned it, remdesivir, dexamethasone. These are well-known treatments that are only generally used in late stages. They're not used early on because dexamethasone is an immunosuppressant, right? You could be used at the wrong time. It can actually be harmful. So we're still waiting for that Tamiflu for COVID.
I thought it was very interesting that the president of Gilead, the company that makes remdesivir, presented that the complexity of making the remdesivir, which we have a shortage of, is that it's sourced from 14 countries, and it takes a meticulous 6 months to make it. So it's not only a very complex scientific product, but also diplomatic product, because you have to have cooperation from all these countries. They were saying that they thought that they'd be able to resolve the shortage by approximately October, and that they felt confident that their work to create a version of it that could be perhaps administered in a nasal spray very early on after a positive test would make sense, that they were pursuing that. I don't know where that is. Does anybody else know about the earlier versions that don't have to be administered in the hospital?
No, I mean, we obviously used it in the first case in February of our patient, and we have noted in our patients, and we really reserve it for those who are sick and in an ICU setting, where it has made a reduction in the number of days that they're in an ICU or on a ventilator. And I think that is an improvement, but it is not and has not been a cure. So that some patients who wind up on remdesivir, that's not enough to actually get them off the ventilator or necessarily save their lives. We still have problems with it. So it's a combination of therapies with different kinds of ventilation, the so-called prone ventilation that has been helpful for us in these severe cases. Remdesivir early on in the acute setting for it, and dexamethasone in the late stage when you have the surge of inflammatory agents for that. And I think we've gotten better. I think we've been able to probably cut our mortality in half, especially since we're not overwhelmed with patients and we have time to work on them individually. So I think all of that has led to a reduction in the mortality that we've seen, as well as Bob mentioned, the denominator is always important, and we really, with more testing, are identifying more patients, so that's coming down. But it is still a serious disease, and it is much more deadly than influenza. And I think it's in the neighborhood of 10 to 20 times more deadly than influenza for mortality. So it's certainly to be respected in those individuals. And we still have in the US about 1,000 people dying every day, roughly. So we can't say that we have solved this problem when we're still looking at 1,000 people a day. And the estimates using other modeling would suggest that we're probably going to get to perhaps 2,000 deaths a day in the US before this is all over. So it's a serious problem, and it likely will get worse before it gets better.
Well, I would like to really make a plea for everyone to use masks diligently, because I am a person who's been told by my specialists that if I contract this, I am not likely to pull through. So that's why I'm being so careful. I have had, many pneumonias in my life. And so when I see people not wearing masks, it really makes me angry, because they're saying they don't care if I die. They don't know me. They don't care if anybody dies. To me, not wearing a mask is a sign of extreme arrogance and stupidity. So I'm being extremely blunt, much more so than usual, but I would really like to see our nation have a fining structure for people who don't wear masks. If you can't wear a mask, wear a face shield for the sake of your fellow human beings. It's just not right to threaten other people's lives. So, with
Okay,
thank you, Steve.
Yeah,
Patty, unfortunately, I'm late for another meeting, so I'm going to have to
Yeah,
run.
with
But
that,
just a
I
parting
thank you
shot
very,
that
thank you very much, Bob, and
Oh,
all
wait,
of our
Bob is
speakers.
still, Bob has something further to say. Go ahead,
Go
Bob.
ahead.
what I was going to say is, first of all, thanks for having me, and that I am really thankful that we have people like Bill and other excellent clinicians to care for people who get sick with this illness, and that it's great that we're making a little bit of progress with therapeutics. But as a public health person, I do have to say that it's very much like heart disease. It's better not need to be rescued, and that I do think, Hattie, that it's imperfect. People are going to get sick under the best of circumstances, but I think we do know enough about this that we can dramatically reduce the number of people who get infected. And as vaccines come along, which I'm confident they will eventually, we can make a lot of progress. And not that we want to put clinicians out of business, but that I think that we really need to double down on the preventive side of this. And the last sort of parting shot is I'm very disturbed about our polling data on vaccine resistance. So it's a problem that's going up, and that we need thoughtful public policies that are going to restore confidence in these sorts of things.
We
So
need
anyway,
some
thanks so much for having me. I'm sorry I have to run, but
Thank you so much.
Thank
That
you very
for
much,
wonderful
Bob.
presentation.
That's excellent. And I think we're at the end of our time at 2:30. So we want to thank all our speakers, Martha and Bob, for excellent presentations, comprehensive today, to start us out and thinking about these issues, all of which can significantly benefit our patients. Thank our chairman who have been on board. Thank our Right Care staff for getting all of the logistics down and the slides and everything going. We certainly appreciate that. As we zoom on into the future, it gives us excitement that what we can do in the future. And for the members who joined us in our support group that supports the Right Care, we certainly appreciate you. And for those members who have joined just for today's program for CME credit, go to the chat line. We will leave it open a little bit longer so you can get the link, which is www.surveymonkey.com, with a link that you'll see on the chat line. That will allow you to fill out the survey, not Bob's survey, but your CME survey for today. And that will allow you to get 2 hours of credit for today. So we certainly want to thank everyone for joining us today. We had a big crowd. We had exciting talks, and hopefully this prepares us for tomorrow as we go forward with the two problems that we discussed today. So thank you very much, everyone, for joining us, and we look forward to our next presentation.